A unified sense of self is a fragile construct. Under the influence of a high-dose psychedelic, that structure can rapidly destabilize, splintering into a chaotic swarm of disconnected thoughts, terrifying emotions, and physical distress. Popular culture dismisses this acute psychological fragmentation as a bad trip, but in a clinical context, researchers use a precise term, the challenging experience. This reaction occurs with classic psychedelics, compounds like psilocybin and LSD, that act as agonists on the brain's 5-HT2A serotonin receptors. Historically, psychiatry treated these acute adverse reactions with immediate suppression. Clinicians used pharmacological sedatives to abort the session and end the distress as quickly as possible. Modern psychopharmacology approaches these challenging states as complex psychological events. These episodes require active management to ensure they contribute to the therapeutic process. To study these events, researchers rely on a core metric, the Challenging Experience Questionnaire, or CEQ. The CEQ maps the chaos of an adverse reaction by measuring 7 specific factors: grief, fear, feelings of death or insanity, isolation, physical distress, and paranoia. Translating subjective patient reports into the standardized data of the CEQ provides the empirical clarity required for rigorous clinical oversight in modern psychedelic-assisted therapy. Before analyzing long-term outcomes, clinicians must establish exactly how long these acute states of distress last. To find out, researchers conducted a large-scale survey, specifically isolating the most difficult psilocybin sessions. This chart shows the distribution of durations for these challenging experiences. 31% report the psychologically difficult window resolves in under 60 minutes. However, 40% experience these challenging states for over 2 hours. A standard 25 mg clinical dose of psilocybin has an acute action window of roughly 5 to 6 hours. This survey data indicates that psychological distress can occupy nearly half of that entire pharmacological session. This extreme variance in duration dictates how clinical sites are resourced. A dedicated therapy team must be prepared for anything from brief anxiety to several hours of severe psychological fragmentation. Establishing this temporal blueprint prevents clinical panic. It prepares therapists for the extended stamina required to stay present through a prolonged adverse reaction. These durations are not fixed, but highly sensitive to external variables that actively manipulate intensity. Beyond environmental factors like set and setting, active pharmacological interference can significantly and immediately alter the psychedelic experience's profile. In naturalistic settings, cannabis is the primary modulator introduced, which actively changes the psychedelic effect. This radar chart maps how cannabis alters the 7 CEQ factors. The innermost line is the baseline without cannabis. Low and medium doses expand the footprint, increasing intensity. High doses trigger nonlinear exacerbation, causing significant spikes in fear, grief, and insanity. This proves that challenging experiences are predictable states that react specifically to pharmacological variables. This raises a critical clinical question. If a patient endures hours of intense fear and grief, does the session ultimately fail? Clinicians measure long-term symptom reduction, focusing on depression and anxiety scales like the PHQ-9 and GAD-7. The baseline for a successful session is a high score on the Mystical Experience Questionnaire. These plots chart session scores against changes in depression and anxiety. In the top rows, high MEQ scores reliably predict significant symptom reduction, but shifting focus to the CEQ scores in the bottom rows, the trend lines remain almost perfectly flat. This proves that acute panic, fear, or paranoia do not predict a failure to reduce depression or anxiety later. The data confirms that acute psychological distress is an isolated feature, entirely decoupled from long-term clinical outcomes. Because challenging experiences don't preclude positive results, clinical protocols focus on navigation rather than abbreviation. Researchers use the responses to challenging psychedelic experiences inventory to map how patients navigate these moments. The data identifies specific strategies as maladaptive. Attempting to physically escape or deploying active cognitive resistance are linked to poor outcomes. This creates a feedback loop that intensifies paranoia and physical distress, leading to lower scores for emotional breakthrough. In contrast, the most effective adaptive strategies identified in the data are acceptance, meaning-making, and reappraisal. The inventory data indicates that patients who utilize these acceptance strategies achieve significantly higher scores for emotional breakthrough. These breakthroughs serve as a primary mechanism for the session's eventual clinical success. The clinician's role is providing social support and sensory regulation to interrupt maladaptive resistance, guiding the patient toward acceptance. By mapping the CE profile, controlling modulators, and employing active acceptance strategies, clinicians can guide patients through intense acute distress and convert a difficult session into a measurable therapeutic success.